So guys, my name is Dr. Wajid Khan. I am an anesthetist and intensivist. So guys, I'll be dealing with this topic of anesthesia. Let us start with this topic called as monitoring in anesthesia. Monitoring in anesthesia. So guys, in the monitoring in anesthesia, now just now we have covered the general anesthesia, right? So during general anesthesia, you have to monitor some things. Monitor some things means what? You have to monitor the vitals of the patient. Vitals of the patient. Vitals include what? You have to monitor the patient's oxygenation. You have to monitor the patient's ventilation. You have to monitor the circulation, and you have to monitor the temperature. Oxygenation, ventilation, circulation, and temperature should be monitored. How will you monitor the patient's oxygenation? The patient's oxygenation can be monitored by just placing a pulse oximeter. Oxygenation can be monitored by pulse oximetry. How will you monitor the patient's ventilation? You monitor the patient's ventilation by looking at the chest movement and by looking at a device called as, basically you look at the chest movement. If the patient's chest is deflating and expanding well, that means he is being ventilated well, right? So you monitor the patient's ventilation by chest movement, and after intubating you can connect this endotracheal tube to a device called as capnograph. This capnograph measures the exhaled carbon dioxide. This is the exhaled phase of carbon dioxide. This is the exhaled and the inhaled phase, right? So capnograph measures the exhaled carbon dioxide. Okay. So ventilation can be monitored by two things. One thing is ventilation can be monitored by chest movement. The other thing is ventilation can be monitored by capnography. What does capnography indicate? Capnography detects the exhaled carbon dioxide. Exhaled carbon dioxide. That's regarding what? Ventilation. So you have monitored oxygenation, you have monitored ventilation. Now you have to monitor the patient's circulation. How will you come to know the patient is being adequately circulated or not? By looking at what? By looking at the blood pressure. By looking at the blood pressure. By just not looking at the blood pressure. Okay, just repeat this once again. How will you monitor the patient's circulation? The patient's circulation can be monitored by blood pressure monitoring, by ECG monitoring, and by TEE. Blood pressure, there are two kinds of blood pressure. One is invasive blood pressure monitoring, other is non-invasive. The blood pressure that we use commonly in our day-to-day life is the sphygmomanometer. That is a non-invasive. That's a non-invasive. And the blood pressure which is invasive is called as what? Invasive is used in what, guys? Invasive means what, first of all? Invasive means you are placing a cannula inside the artery and you are measuring the blood pressure. Which artery? Radial artery, femoral artery. You put the cannula in the radial artery, femoral artery, and then you measure the blood pressure every second. That is called as invasive blood pressure monitoring. So for invasive blood pressure monitoring is usually done for major cardiac surgeries. Non-invasive monitoring is done for almost all surgeries, but invasive monitoring is done for major cardiac surgeries. So invasive and non-invasive monitoring in the blood pressure, right? So circulation, we have monitored the blood pressure, we have monitored the ECG. In ECG, many leads are there. 12 leads ECG is there. All 12 leads are not important. Your eyes, your focus should be on only two leads. What two leads in the ECG? Lead 2 and lead 5. Lead 2, if you monitor lead 2 correctly, you can easily detect intra-op arrhythmias. With lead 5, you can detect ischemias. Lead 5, you can detect easily ischemias. So lead 2, you can detect arrhythmias. Lead 5, you can detect ischemia. Next, in the circulation, the next thing that we monitor is TEE. So circulation can be monitored by BP, ECG, and TEE. TEE is a sophisticated monitoring which is required for major cardiac surgeries in which you are suspecting air embolism, right? TEE is trans-esophageal echocardiography, where you introduce the endoscope with an echo probe, and you take that endoscope, you put that endoscope into the esophagus, and you take it till the level of the heart, and then you scan the heart. That is called as trans-esophageal echocardiography, again done for major surgeries where you are suspecting air embolism. Air embolism. Last thing that can be monitored is what, guys? The temperature. You can monitor the patient's temperature. In the temperature, guys, remember, for almost all small surgeries, you require a peripheral temperature monitoring. But for major cardiac surgeries, it should be monitored by checking the patient's core temperature. There are many sites for checking the patient's core temperature: tympanic membrane, nasopharynx, pulmonary artery, esophagus. The best site for checking the core temperature monitoring is pulmonary artery. The sensitive site for core temperature monitoring is what, guys? Pulmonary artery, where we keep a Swan's-Ganz catheter and we monitor the temperature. Swan's-Ganz catheter. And we monitor the patient's temperature. So remember, guys, 4 things are done in monitoring: the ventilation, the first oxygenation, second ventilation, third circulation, and fourth is what? Fourth is the temperature monitoring. In temperature, I told you there are 2 kinds of temperature. One is the peripheral temperature, other is the core temperature. So for major surgeries, you go for core temperature, and the best site being what? Pulmonary artery. Apart from that, you also monitor the patient's, you also monitor the awareness. You also monitor awareness. How will you monitor the awareness, guys? How will you monitor the awareness during anesthesia? How will you monitor the awareness? Basically, imagine a patient after surgery comes to the anesthetist and he is telling that, "Doctor, during surgery, I was awake. I was able to hear your voices. I was able to hear your conversation. Which team is doing good, or which plot you are buying, and what you have, what you were discussing with the surgeon during surgery, this patient was able to hear." Is it possible, guys? Yes. How? How is it possible? It's possible only when remember, guys, what is the thing that maintains the patient in an unconscious state? Inhalational agent. It is possible for the patient to be aware when the inhalational agent you are using is not working. Sometimes it might happen, guys. Inhalational agents are stored in vaporizer. Sometimes there is no gas in the vaporizer and you have just on the vaporizer. If you just on the vaporizer with no gas, what will happen? The patient will be aware, but he is aware, he is not able to open his eyes and all. Why he is not able to open his eyes? Why he is not able to move? Why? Because you have given a long-acting muscle relaxant, but still he is aware, right? For monitoring whether your patient is aware or not, how will you come to know that your patient is aware during anesthesia, right? How will you come to know, guys? You can't, patient won't be opening his eyes, but how will you come to know? You come to know by a monitoring called as BIS monitoring. BIS monitoring. What is BIS monitoring? It is bispectral index. Bispectral index. Bispectral index, which calculates the sum of EEGs. That calculates the sum of EEGs. With bispectral index, you can calculate the sum of EEGs and you can come to a conclusion that the patient is aware or not, right? So remember guys, in monitoring during anesthesia, these are the points. Now coming to the summary of general anesthesia. This is the most important slide guys. Okay. Basically, I'll give you some hints over here. Here is condition, yani ki patient suffering with this condition. What is the IV induction agent you will give to the patient? What is the muscle relaxant and what is the inhalational agent? Imagine a patient is suffering with heart disease. What is the IV induction agent that you give in heart disease? In heart disease patient, you want to give a cardio stable. Everything you want to give a cardio stable. Whether it is IV, whether it is muscle relaxant or inhalational agent, you have to give a cardio stable. So IV induction agent which is cardio stable is what? Ethomidate. Next is the most cardio. Remember, what is the muscle relaxant that you give in a heart disease patient? You go for a cardio stable muscle relaxant. I will write just V, which looks like heart, which is vecuronium. Vecuronium. Inhalational agent. There is best and most common. The best inhalational agent that is least cardiac depressant is what guys? Desflurane. And which is the most common inhalational agent used for heart disease? Isoflurane. The best is desflurane, but most commonly we choose isoflurane. Next, patient is suffering with bronchial asthma. Patient is suffering with bronchial asthma. Which is the IV induction agent of choice? Bronchial asthma means he is having bronchoconstriction. You have to give a bronchodilator, which is the IV induction agent that dilates the bronchus, which can be given as an in asthma. Ketamine. Ketamine is the IV induction agent. I told you ketamine is the worst enemy of CNS and friend of others. Friend of respiratory means it will cause bronchodilation. Muscle relaxant, any muscle relaxant can be given in asthma. Inhalational agent of choice in bronchial asthma, come on guys, halothane. Halothane. Next, a patient is in shock with a BP of 70/40. If the patient's BP is 70/40 and the patient is in shock, which is the IV induction agent, you make the patient unconscious by IV induction agent, which is called as what guys? Ketamine. Next, which is the muscle relaxant of choice in shock. In shock patient, the muscle relaxant of choice is what? Pan-India movie, pancuronium. Yes, I told you, Pan-India movie, pancuronium. Pancuronium, why Pan-India movie? Why? Because pancuronium RRR. The first R was, it was increasing the rate, BP and pulse rate. So pancuronium is a muscle relaxant of choice in shock. Why? Because both ketamine and pancuronium both are increasing the BP and pulse rate. Next is what? Inhalational agent of choice in shock. Again, same like heart disease, the best and the most common. The best is desflurane, whereas the most common is again isoflurane. A patient is posted for day case surgery. How will you make the patient unconscious? By IV induction. The IV induction agent of choice for day case surgery is propofol. The muscle relaxant of choice for day case surgery is, why did you give propofol? Why? Because it's having a short elimination T-half. The muscle relaxant of choice for day case surgery is mivacurium, the shortest acting non-depolarizing. And the inhalational agent of choice for day case surgery is, I'll give you an option guys, des and methoxy. Which one will you choose? Which one will you choose? You will always choose des. Why? Because it is having a low blood gas coefficient, fast onset, fast recovery. So inhalational agent of choice for day case surgery is desflurane, but most commonly we use sevoflurane. Why? Because desflurane is costly. Next, neurosurgery. For neurosurgery, the best IV induction agent is sodium thiopentone. The best muscle relaxant for neurosurgery is any muscle relaxant. The best inhalational agent of choice for neurosurgery is, I leave this thing to you. Should I leave it to you? Inhalational agent of choice for neurosurgery. Inhalational agent summary was what? If you remember the summary, you can remember it. Summary of inhalational agent for CNS and CVS, isoflurane, respiratory and muscle halothane, analgesia nitrous and trilene. So the inhalational agent of choice for neurosurgery is isoflurane. That this slide is very important. 13 to 14 MCQs are being hidden in this slide. Okay, this is basically the revision of your general anesthesia that we have already discussed. Okay guys, so this was regarding the monitoring. Thank you.